Good morning. Welcome to another webinar on our webinar series. As usual, first to the housekeeping rules. This webinar link will be available from 9 a.m. to 9:45 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. These rules are there to maintain the standards of our CPD program structured here, and we thank you once again for joining us for this webinar series. And without further ado, I'd like to introduce you to our topic, which is very timely, convenient topic, jaundice in neonates, which carry a lot of misconceptions and sometimes mismanagement. As usual, this webinar is brought to you by the Society for Health Research and Innovation. At the end of the lecture, this webinar will be having a question and answer session. So please feel free to type in any queries you have to discuss at the end. We also request you to switch off your video and mute your microphones during the session. Today, we have a very distinguished guest to discuss our topic. She is Dr. Nimesha Gamhewage, the consultant neonatologist at Columbus South Teaching Hospital, who is also a senior lecturer in pediatrics at University of Sri Jayewardenepura. Over to you, madam.
Good morning, ladies and gentlemen. First of all, I would like to thank the Society of Health Research and Innovation for this opportunity. So during the next 1 hour, I'll be discussing about jaundice in neonates, which is a very common scenario we come across in our day-to-day practice. So before I move in with my lecture, I would like to bring your attention into 3 different case scenarios. The first case scenario, you are an on-call pediatric medical officer in the postnatal ward. When you're doing the night ward round, you encounter a day 2-old neonate born at term who is already on phototherapy for jaundice, and you notice that the serum bilirubin is rising progressively despite providing double phototherapy for the last 8 hours. Now the bilirubin level has reached the exchange transfusion line. When you further review the notes, you notice that the mother is O positive while the baby is A positive, but the DAT is negative. You haven't received the blood picture report yet. So how will you assess this baby and how will you proceed? In the next scenario, you meet a 6-day-old baby born at 36 weeks of gestation who has been brought to your private practice as the mother is concerned about yellowish discoloration. You note that the baby's birth weight is 3 kilos, currently has lost 500 grams, and both are A positive. And when you examine the baby, you're a little concerned about the activity of the baby. So will you proceed in this case scenario? In the third situation, you meet a 17-day-old baby born at term and has been brought to your practice due to an upper respiratory tract infection. You notice the baby looks active, well, not in distress, gains weight adequately following birth. However, when you examine the baby, you notice some additional things such as that is, this baby is jaundiced. So what is your approach for this baby? Right. With keeping these 3 scenarios in the back of your mind, I will commence the lecture today with 2 main objectives. Firstly, I will discuss about early onset jaundice appearing in the neonates, and then I'll move on to discuss about prolonged jaundice. So as I mentioned before, jaundice is extremely common. We know that about 60% of term babies can have jaundice, and this is higher in preterm babies, as much as 80%. So when it comes to jaundice, it could be either physiological jaundice or pathological jaundice. Under the pathological variety, we have unconjugated as well as conjugated hyperbilirubinemia. So there are a lot of etiology causing jaundice in neonates. So when you encounter a baby or a newborn with yellowish discoloration, how are you going to assess this baby? First of all, you have to determine whether there is jaundice or not. So how you would determine that is by blanching the skin, as you can see in this photograph. Just blanch the skin, and underneath, if there is no jaundice, you must see the pale color, whereas if the baby is jaundice, you see the underlying yellowish discoloration. After demonstrating that the baby is jaundiced, you want to know the extent of the involvement. So we know that jaundice progresses in a cephalocaudal direction, where you first notice it in the face of a baby, and when it is progressed to severe level, you notice it in the palms and the soles. Therefore, it starts from the face and then goes slowly downwards, next into the chest, next into the tummy, and then into the arms and the legs, and finally you assess in the palms and soles. When you're assessing the severity, it's important to notice the age of the baby. For instance, if this is a day 1-old baby, within the first 24 hours, we know any amount of jaundice is significant and likely to be very high. At the same time, if you see any baby with palms and soles involved with jaundice, again, you know that this is a significant level of jaundice. Please also take into consideration the gestation of the baby. Again, because preterm babies, even a mild to moderate amount of jaundice could actually be severe in degree because their blood-brain barrier is not very functional. Next, an important step is to assess the general well-being of the baby. How is the baby active? Is the baby active? Are the neonatal reflexes present? Is the sucking reflex there? Is the baby feeding? So the general activity is extremely important, and also make a note of the baby's weight. Coming back to physiological versus pathological jaundice. We all have learned this in our medical school. I'm just going to recapitulate. So in physiological jaundice, we know that it never occurs within the first 24 hours of life, whereas pathological jaundice can occur at any time, including the first 24 hours. Bilirubin rise is very slow in physiological jaundice, whereas pathological jaundice is variable and it can be very rapid. Maximum bilirubin level is also not very massive in physiological jaundice. However, in pathological jaundice, this could be very variable. It could even rise above the exchange transfusion level. The peak bilirubin rise we see in physiological jaundice in a term baby around 3-4 days of life. That's when you will see these babies in your practice as well. They are discharged most of the time from the hospital and a little bit delayed, day 7 in preterm babies. However, when it is an pathological jaundice, it could vary. And it is always unconjugated when it comes to physiological jaundice. However, in pathological, it could either be unconjugated or conjugated. And we expect those with physiological jaundice to resolve their jaundice by 14 days of life, whereas in pathological jaundice, this could vary. So physiological jaundice occurs. So therefore, you can see that physiological jaundice is very common, and it mainly occurs in healthy babies who are breastfeeding really well and with normal activity and just a mild to moderate level of jaundice. They are not of a major concern. However, we have already seen that pathological jaundice can lead to serious concerns. First of all, we'll look into the etiology of unconjugated hyperbilirubinemia leading to pathological jaundice. So you have a couple of important mechanisms here. First of all, you have hemolysis, and then babies with sepsis, breastfeeding jaundice or starvation jaundice. Those with polycythemia, again, more common to present with jaundice, and rarely in born errors of metabolism and other endocrine causes. Moving on to hemolysis, the common scenarios would be a baby having hemolytic disease of the newborn, commonly due to ABO incompatibility, and could also be due to RH incompatibility. Here we have a baby born to a mother who is O, who belongs to O blood group, and baby could be either A, B, or AB. So we see early onset jaundice in these type of babies, and this can rise to very high levels. However, the hemolysis is not as bad as you see in incompatibility, uh, RH incompatibility situation. So RH incompatibility is not, we don't see it very commonly these days because of the preventive measures that the obstetric team takes, their ROGAM and all that. Because of all that, we see severe amounts of jaundice due to RH incompatibility less commonly nowadays. However, both are very important etiologies, as we know that the bilirubin level can rise to very high levels, leading to complications. Rarely you might encounter a baby with membrane defects and RBC enzyme defects. Cephalhematoma is also a common cause of jaundice in babies due to hemolysis, where they have a collection of blood outside the brain, and this blood also undergoes hemolysis, leading to jaundice and even prolonged jaundice. So neonatal sepsis, sepsis, sometimes we pick babies due to sepsis, when they present with jaundice. And also as a complication, those with sepsis can develop jaundice. So whenever you see a baby with concerns related to sepsis, it's worth noting the jaundice level in this baby. Breastfeeding jaundice is due to poor feeding, leading to dehydration of the baby, and this is commonly related to poor latch in the baby, leading to poor milk intake, and these babies are generally dehydrated and could even be lethargic and jaundiced. The good thing is these babies quickly improve when you improve the hydration and improve the intake of breast milk. Polycythemia, again we see in some babies, especially those who are born to mothers with diabetes mellitus, either gestational diabetes mellitus or pre-existing diabetes. This is again because they are polycythemic, there's a high rate of red blood cells breakdown, and these babies develop jaundice. We have discussed about sepsis already. So the common investigations you want to undertake in this scenario is obviously the bilirubin levels. You want full blood count, a blood picture to look at the etiology, can give you an idea about the hemolysis or the sepsis. A retic count, a normal retic count is up to 5% in a neonate. Anything about this indicates hemolysis. So you need to assess the blood groups of the baby and the mother, direct Coombs test. Please keep in mind that the direct Coombs test can be negative in ABO incompatible scenarios, whereas it's always positive in those with RH incompatibility. Septic screening is not a must, but should be done if you suspect sepsis in this baby. Otherwise, for a baby who is having jaundice, but apart from that, well-looking, active, feeding well, doesn't need a septic screening at all. Management. When it comes to management of a baby with unconjugated hyperbilirubinemia, we can use several modes. Essentially, you have to use phototherapy, and depending on the level of hyperbilirubinemia, you will be using either single, double, or triple phototherapy units. Hydration is extremely important to flush away that bilirubin from the system. And in immune-mediated hemolysis, that is in babies with ABO incompatibility and RH incompatibility, there is a major place for IVIG. We cannot forget about exchange transfusion, although we do it less commonly nowadays. That is also a very important treatment option we have, especially when babies present to us with neurological abnormalities due to very high bilirubin levels. And lastly, but not least, improving the efficiency of breastfeeding, extremely important. So when we are assessing the level of the bilirubin level to decide on the treatment, these are the charts we use, taken from the NHS, the NICE charts. So there are a couple of things you have to notice when you are using these charts. First of all, you use the gestation specific chart. You can see that this is a chart for a baby born either 38 or above weeks of gestation. So you have gestation specific charts for babies for each gestation below this. And then next, notice that we use the total SPR rather than indirect bilirubin level. And you have to be very careful when you're plotting it to use the age of the baby when the sample was collected, rather than when you receive the investigation. That is very important if you consider this initial 2 days where this line is very steep, and even the slightest change, miscalculation in the age of the baby can lead to complications. So this is your exchange transfusion line, and this is your phototherapy line. And mind you, during the first 24 hours, the exchange transfusion line and the phototherapy line lie close to each other. So it's very important when you are interpreting the bilirubin level in a very young baby. So phototherapy is the main mode of treatment for unconjugated hyperbilirubinemia. So we all know that it converts bilirubin into lamirubin via structural isomerization so that it's easy for the kidneys to excrete bilirubin. So we commonly use these overhead phototherapy units, but some hospitals do have these bilirubin blankets or blankets, which are very convenient to use, and the mother can even breastfeed the baby while using these Billy blankets. So when you're delivering phototherapy, we must ensure that the baby is unclothed as much as possible. We close the eyes to reduce the eye damage, and we need to turn the baby from side to side. And there are a couple of complications, especially changes in the temperature, such as hypothermia. So we have to monitor the temperature, especially in preterm babies. And these babies could get complicated with dehydration. Therefore, it's very important to assess the hydration status and correct it if necessary. However, if your bilirubin level is very high, let's say very close to the exchange level, on the exchange level, or above exchange level, please remember that you should never interrupt phototherapy to allow breastfeeding. These babies should obtain uninterrupted phototherapy throughout to make sure that the bilirubin will come down nicely. So in these babies, you have to go for alternative methods of feeding, such as giving express breast milk via the cup while the baby is still receiving phototherapy, or giving it via an NG tube, or using intravenous fluids if the baby is not tolerating enteral feeds. However, if the bilirubin level is in safe margins around phototherapy level, maybe just on the line or just above phototherapy level, then it's quite safe to discontinue phototherapy time to time, just to come out take the baby out for a feed, 20-30 minutes with the mother, but to go back to receive phototherapy. So important complications include dehydration, erythematous rash, hypothermia. So these issues has to be identified and addressed. And more importantly, maternal anxiety is extremely important to address. And you just want to talk to this mother regarding this. When the baby is receiving bilirubin, please notice that it is the assessment of the bilirubin. You cannot do it with your inspection, because the skin bilirubin goes away very quickly. Therefore, it's very deceiving. You have to do serum bilirubin assessments at least 6 hourly. And you stop the phototherapy when the serum bilirubin is at least 50 micromoles per liter below the phototherapy line. And it's a good practice to always check the rebound bilirubin after you stop it. You stop the phototherapy and you wait for 6 hours and recheck for rebound hyperbilirubinemia before you discharge the baby home. Exchange transfusion is not very commonly done these days. However, that is also an important element when we are managing babies with very high levels of indirect hyperbilirubinemia. The important indications that you need to keep in your mind, especially the clinic, if a baby is having clinical features of bilirubin encephalopathy, that we will discuss in few minutes. And also, you have to consider exchange transfusion if the severe hyperbilirubinemia is not responding to your medical management with phototherapy and proper hydration. Intravenous immunoglobulins have been very useful, and it has actually prevented the need for babies to undergo exchange transfusion nowadays. However, remember The use is only for those who are with immune-mediated hemolysis. So that is for ABO incompatibility or RH incompatibility hemolysis, where there's a very rapid rise in the serum bilirubin level. So you in these babies use, let's say the mother is O positive and the baby is A positive. You can suspect ABO incompatibility in these babies, and you start phototherapy for the baby. If there is if there's a poor response and the bilirubin is not coming down as you have expected, you can always give the immunoglobulin over 2 hours, and you can assess the response. So this prevents the need for giving for performing exchange transfusion. Please note that there's no place for giving FFP in babies with severe hyperbilirubinemia. This has been a practice in the past, but now outdated, and it is no more recommended. So moving back to the first case scenario I have given before we started the lecture. So you are the on-call pediatric medical officer and you encounter this baby born to O positive mother, baby is A positive, DAT negative, and was started second day of life, was started on phototherapy. However, the bilirubin is rising rapidly and not coming down as expected. So this is a typical scenario of ABO incompatibility. Mother is O positive, baby is A positive, DAT is negative. You don't actually need a blood picture here, you know the diagnosis. So what is the main element of assessment here? So you have a baby with very high levels of bilirubin. Your main concern is whether this baby is having features of bilirubin toxicity, bilirubin encephalopathy. So you have to assess this baby, whether this baby is having those features. I will discuss about that later. What should be the ideal management for this baby? So now this baby who is in the ward should be moved on to the neonatal intensive care, and we have to optimize the phototherapy with going to triple phototherapy. And without wasting time, this baby needs an intravenous immunoglobulin dose to stop that rapid hemolysis. So that is the ideal management. And also for the second case scenario, a 6-day-old baby born at 36 weeks of gestation, who is coming to you with jaundice. You also notice that baby has lost 500 grams from the birth weight. So that is a very significant weight loss for this baby on day 6 of life. The maximum amount of weight that a newborn can lose within the first week is 10% from the birth weight. So you can see that this baby has lost more than that. Both mother and baby are A positive, and you are concerned about the activity of the baby. So the main concerns in this baby is, first of all, this is a preterm baby. So even in the charts, the threshold to start phototherapy as well as exchange transfusion level is very low in babies born at 36 weeks and below because of the immaturity of their blood-brain barrier. Here you are concerned about the activity of the baby. You'll never know whether this baby is already showing you the features of bilirubin encephalopathy. So this baby needs attention urgently and to be transferred to a hospital as quickly as possible to commence hydration as well as intensive phototherapy. So the likely cause in this baby for the jaundice is breastfeeding jaundice, where this baby, due to improper feeding technique, this baby has got dehydrated, leading to jaundice. Now, because I have been talking a lot about neurological dysfunction in those with very high bilirubin level, I think it's time for us to discuss about bilirubin-induced neurologic disorders, or BIND. So this is why this talking about early onset jaundice, managing babies with early onset jaundice is extremely important, because in these neonates, bilirubin crosses the blood-brain barrier. If the levels are high, the bilirubin crosses the blood-brain barrier when it's unconjugated. and binds to brain tissue, especially the brain basal ganglia and the brainstem nuclei for oculomotor and auditory function, and cause major neurological dysfunction in these babies. So there's a spectrum of neurological injuries. In the acute phase, you see acute changes and acute bilirubin encephalopathy, where you see a baby who is, so this is the picture I have used to show you the features of acute bilirubin encephalopathy. Again, we can identify several stages of acute bilirubin encephalopathy as early, intermediate, and advanced. So in the early phase, very subtle features, it might be difficult even to identify these babies as having acute bilirubin encephalopathy. So you see a baby who is little sleepy, less active, but arousable. When you examined, you feel the tone is little low. These babies might have high-pitched cry, but the good thing is if you start treatment early, these are reversible. And then when they move on to the intermediate stage, they are very lethargic. They have poor sucking or they are irritable with jitteriness. They're very difficult to console. They are crying all the time. And now these babies develop mild to moderate hypertonia. Initially, it will be intermittent arching of the neck or the trunk, which we call known as opisthotonus, when you stimulate or when you want to examine the baby. And these babies, while you are starting the treatment with phototherapy and hydration, maybe IVIG, you have to get ready for a very urgent emergency exchange transfusion if you are to prevent further damage. In the advanced situation, the babies are very sick. They go into apnea, they don't feed, they might have fever, seizures, they are very irritable, they are in a continuous status of hypertonicity with persistent retrocolis and persistent opisthotonus, and they might even have abnormal movements like bike cycling or twitching of movements, and they can even die due to cardiorespiratory arrest or uncontrollable seizures. So the kernicterus, which we have all heard about this in the medical school, that is due to chronic bilirubin encephalopathy. And we all have learned about this. These babies, they come with chorioathetoid cerebral palsy. They can also have sensorineural hearing loss and also gaze palsies, limitation of upward gaze especially. But in general, their cognitive function is relatively spared. So this is why you need to identify babies in early stages of jaundice, assess them carefully, and manage them properly. It is very sad to know, even in the current dates also, we see babies developing bilirubin encephalopathy and leading to kernicterus. It's a shame if a baby develops kernicterus. It is a failure of the whole medical system. Therefore, it's extremely important to identify these babies, assess them properly, and start the treatment appropriately. And if the need is there, if the baby is showing you the features of bilirubin encephalopathy, without wasting time, to go for an early exchange transfusion, that will save this baby. Now I'm going to move on to prolonged jaundice. Right. So prolonged jaundice means jaundice persisting for more than 14 days of age in a term baby or 21 days in a preterm baby. This could be either indirect hyperbilirubinemia or direct hyperbilirubinemia. The common causes for indirect hyperbilirubinemia is urinary tract infections, breast milk jaundice, continuous hemolysis, very rarely congenital infections. You have to always think about hypothyroidism, or rarely inborn errors of metabolism. When it comes to direct hyperbilirubinemia, although there are a lot of causes, the main thing you shouldn't miss and you should aim to identify early is the case with biliary atresia. It is a very urgent scenario here. So there are a lot of investigations that these babies have to undergo depending on the situation. So you don't have to do all these blood test investigations in all the babies, but generally, if it is a baby with the first investigation, the first assessment, the first question you are going to ask from this mother who is bringing in a baby with prolonged jaundice is to determine the stool color and to determine the color of the urine. If there is pale stools together with dark urine, then you know it's a conjugated hyperbilirubinemia. And if it is normal color stools with quite pigmented stools with normal color urine, pale urine, then you know this is indirect hyperbilirubinemia. However, anyhow, irrespective of your clinical assessment, you have to go ahead and do a fractionated bilirubin test to determine whether this is an unconjugated hyperbilirubinemia or conjugated hyperbilirubinemia. If it is unconjugated hyperbilirubinemia, the commonest causes we know are urinary tract infections, hypothyroidism, and prolonged hemolysis. So if you need to do the baseline assessment, then you know the investigations you want. You need thyroid TSH done at 8 o'clock in the morning, and you definitely need the blood picture of this baby and urine culture. If that is a conjugated hyperbilirubinemia, the main thing, the first etiology that you want to exclude would be biliary atresia. And that you need to do a very urgent ultrasound scan of the abdomen after keeping the baby fasting for 4 hours to see the gallbladder. So I'm moving on to conjugated hyperbilirubinemia. So you diagnose this depending on your fractionated bilirubin levels. If your conjugated fraction is about 20% of your total bilirubin, irrespective of your bilirubin level, you are going to consider this as conjugated hyperbilirubinemia. In addition, these babies might have deep jaundice and pale-colored stools and dark-colored urine. So you see these are the normal colors of stools in babies, very pigmented. And these are quite abnormal stools, very pale-colored. So biliary atresia is the most important entity to exclude or diagnose early when it comes to a baby with prolonged jaundice. So it's a progressive disease where there's a destruction or absence of extrahepatic biliary tree. And if you have not identified these babies early and not done the surgery in the proper time, this leads to chronic liver failure and death. So generally these babies are healthy at birth, they are born at term, normal birth weight, but they develop jaundice and that progresses into deep jaundice with pale-colored stools and dark urine. They develop very early hepatomegaly. So how you diagnose? First investigation you want to do is to do a fasting ultrasound scan of the abdomen. And that's when you can diagnose if there's biliary atresia, the gallbladder will still look very contracted or absent gallbladder in the fasting ultrasound scan. So if you see that, you have to quickly refer this baby to a surgeon to get the further investigations or the Kasai procedure done before the baby turns 6 days old. Urinary tract infections are a common cause of unconjugated, indirect hyperbilirubinemia, leading to prolonged jaundice. These babies are usually asymptomatic. So when it comes to urinary tract infection in newborns, they usually don't present to us with the typical dysuria symptoms. So it's very common for babies to cry before passing urine and also to cry after passing urine. However, if a mother says this baby is passing urine while crying while passing urine, that's a very important symptom to consider. And you need to think about urinary tract infection. It's very common for them to have poor weight gain when they are having urinary tract infections. So make sure you exclude that. Congenital hypothyroidism, again, a very important cause not to miss, although it's rare, it's important that you are not missing a baby with congenital hypothyroidism when they present with prolonged jaundice. Although I have shown these classical features in this picture with coarse facial features, large protruding tongue, umbilical hernia, most of the babies will not show these features around the time of birth. So you might miss the clinical features. We do perform Guthrie test in all the babies to diagnose congenital hypothyroidism, but if you have the suspicion, if you see a baby with prolonged jaundice and not settling, it's important to exclude this with the TSH level done at 8 weeks, around 8 o'clock in the morning. And finally, breast milk jaundice. It is a diagnosis of exclusion. Breast milk jaundice we see in babies who are healthy, who are putting on weight, exclusively breastfed babies, who keep on having jaundice beyond 2 weeks of life. And this is due to a substituent in the maternal breast milk, which converts the conjugated bilirubin into unconjugated form in the intestine, so that the baby keeps on absorbing unconjugated bilirubin from the intestine into the circulatory system. So in these babies, the main features are they are healthy babies, they are putting on weight, they are being exclusively breastfed, and when you examine apart from jaundice, they don't have any other abnormality. And we also know that this can persist up to about 3 to 10 weeks. So just the reassurance is what is needed. You reassure the mother and just tell her when you continue the breastfeeding, the jaundice will disappear and the baby will put on weight and baby will be healthy. So you should never advise these mothers to stop breastfeeding. Although it's called breast milk jaundice, you have to promote breastfeeding in these babies as well. So now I'm moving on to case scenario 3, where a 17-day-old baby born at term is brought to you for some other concern. But when you have examined this baby, you see this baby is having prolonged jaundice. This baby is active. Rest of the examination is normal and baby has put on weight since birth. So here, your main objective is to make sure that you are not missing important differential or important etiologies leading to prolonged jaundice. The most important disease that we all want to exclude would be biliary atresia in this situation. However, given the history, it is likely that this could even be a breast milk jaundice, but don't be in a hurry to come to that conclusion before doing a proper evaluation. You need to at least do a fractionated bilirubin level with your total direct and indirect levels in this baby to come to a conclusion. Right. That brings us to the end of our presentation today. So I would recommend these 2 guidelines for further reading. So we have 3 books published by the Ministry of Health together with the WHO, known as National Guidelines for Newborn Care. There are 3 volumes, and in the second volume you find a comprehensive account on neonatal jaundice, where we discuss about the etiology, how to assess and manage complications, and everything. And then you cannot forget about the NICE guidelines, which again gives a comprehensive, a detailed description about neonatal jaundice, and you can obtain the NICE charts, the bilirubin, the reference charts for bilirubin levels for all the gestations in these charts as well. So both these guidelines are freely available to be downloaded in the internet. So in summary, if the take-home messages would be only to, if you encounter a baby with early onset jaundice, the primary aim for you is to prevent bilirubin-induced neurological damage. the encephalopathy. So identification of these babies is extremely important, and referral to a unit with the adequate facilities which can manage these babies, and to institute proper treatment correctly and quickly to prevent occurrence of acute bilirubin encephalopathy as well as kernicterus is extremely important. Secondly, when you encounter a baby having prolonged jaundice, that means jaundice persisting beyond 2 weeks in a term baby and beyond 3 weeks in a preterm baby, the main aim for you is to exclude biliary atresia, because we know if this is not identified early and treatment not instituted early, these babies can invariably they are going to develop a chronic liver disease needing liver transplantation, and that's going to make their lives quite miserable. So thank you very much for your patient listening. We can now discuss any questions if you have.
Thank you, Madam, for that very informative and concise lecture. We have few questions, Madam. First one, NK has asked, in ABO incompatibility, that is most of the time positive?
Yeah. So thank you for that question. So actually what we see in ABO incompatibility hemolysis is DAT, or your direct womb test, is not usually positive. It's usually negative, but sometimes very occasionally only we get this positive. So even if you get a mother with O positive blood group, baby A or B, and in the blood picture, just having hemolysis is sufficient for you to diagnose ABO incompatibility in this baby. And usually you see a reticulocytosis also more than 5% reticulocyte count. And that's enough. You don't need the DAT. But in RH incompatibility, generally, usually the DAT is positive.
And we have another question, Madam. Taranga has asked, when do we have to do the full list of investigations in jaundiced baby who is more than 2 weeks old to diagnose the cause? Hope breast milk jaundice is diagnosed after proper investigations.
Yeah. So yes, breast milk jaundice is a diagnosis of exclusion, but you definitely need to see a healthy baby who is a happy baby who is gaining weight, and the examination findings should be completely normal. But just remember, you don't have to do a full panel of investigations just to come to the diagnosis of breast milk jaundice. The first most important investigation in all these babies with prolonged jaundice is a fractionated bilirubin level, the total, direct and the indirect. So if you see that it's an indirect hyperbilirubinemia, your baseline, the first line investigations should include a blood picture to see if there is a hemolysis, and then a TSH done at 8 o'clock in the morning to exclude hypothyroidism, and a urine culture. So these three tests generally would identify most of the pathologies which is causing indirect hyperbilirubinemia. If everything is normal and baby is gaining weight nicely, developing the milestones nicely, you see the you see the examination, everything is normal, and then you can wait rather than going to do the full set of investigations. You see, if you take causes for prolonged jaundice, the list is exhaustive, so you don't have to do all these tests. However, if you feel like this baby is having, the jaundice level clinically is getting worse, and the bilirubin level is also, not coming down, and then at that point, it is worth referring this patient to a tertiary care hospital pediatric clinic for further evaluation. However, if your first bilirubin showed a conjugated hyperbilirubinemia, you can't waste even a minute. You have to quickly refer this child to a pediatric surgical unit then and there.
Madam, we can go for another question before we wind up. What is the place of transcutaneous bilirubin measurements in diagnosis of jaundice. Is it used in our setup? And can you differentiate between unconjugated and conjugated bilirubin?
Yes, so transcutaneous bilirubin meter is a useful thing that is available in other developed countries. Unfortunately, it's not available in our country. So it's a good screening test. When we do a round in the postnatal ward, we sometimes, you might agree with me, we order about 5 bilirubin tests, but most of these bilirubins are below the phototherapy range. You don't have to treat these babies. So in other countries, what they do is this type of babies, they check their bilirubin using this transcutaneous bilirubinometer. And if the level is high only, we go for the venous specimen and we check the bilirubin level. The problem with it is, of course, it cannot differentiate conjugated or unconjugated. It just gives you the total value of bilirubin only. So it's a valuable tool in the initial period for you to see whether the bilirubin level is high or not. And it is useful in it will be, if available, it will be useful in our population also. Even though we are dark skinned, it works well in our babies as well.
Thank you, madam. Unfortunately, that's all we can discuss today. For those who couldn't clarify the queries today, can send them to us as Sri. So then we can ask from Nimesha madam and we'll let you know. And thank you so much, madam, for that concise lecture. And we sincerely appreciate your attention this morning. For the participants, please fill the feedback form to get your e-certificate. And for those who couldn't join the lecture today due to network problems or other issues, can listen to the lecture in our YouTube channel. Thank you very much once again, and we'll meet next week with another webinar. Thank you.
Thank you very much.